Good afternoon. Thank you for the invitation to present a few pieces of work that I've been involved in over the past few years, which have been focusing on the financial burden of cancer and how the transparency of costs in cancer care, both in private and public systems, could be improved. My name is Kate Whittaker. I'm currently the Manager of Cancer Care Policy at Cancer Council Australia, where I oversee the development of our national policy positions on topics that relate to the care and treatment of people with cancer. My background is in policy. I'm not an implementation researcher, but I have worked with some over the years, and particularly in some of this work. I do have an interest, though, in bringing together the research and policy to answer those challenging questions in healthcare where we currently don't yet have the evidence or need to pull together the evidence to really make our case for change. I'm really keen to hear about projects you're working on or are on your wish list. And considering how, research projects can be developed with policy and practice implications in mind, so people can really benefit from your important work. I do apologise for cancelling the other week. A virus really got me, so I appreciate your understanding and really welcome any follow-up questions or connections you might want to make. My email's there, and I invite you to get in touch. So before I begin, I'll just would like to acknowledge the traditional custodians of the country on which I'm presenting, this work to you today, and pay my respects to their elders past, present, and extend all respect to Aboriginal and Torres Strait Islander peoples today. I'm recording this webinar for you from the traditional lands of the Dark and Young people, and recognise that cancer disparities exist in our population, and we really need to work towards reducing those gaps. So for my presentation today, I'll just introduce the concept of financial toxicity and its context in Australia, then talk to a few pieces of work from the past several years, which has progressed the conversation of out-of-pocket costs from looking at the issue to looking at it from an impact perspective, and to a more recent implementation-focused research project we've completed on informed financial consent, and just finish with where to next for financial toxicity. So I think interestingly, the conversation has shifted a little bit over the years from solely focusing on how much a person pays out of pocket for healthcare to understanding all the financial costs following a cancer diagnosis, and in particular the impact of these on their healthcare decisions. It's also moved away from the impact to an individual patient or person to the broader impact on the household and their ongoing financial security. So as the cost of delivering cancer care has increased, conversations about how public funding decisions are made and the role of private health insurance, its premiums, and a reliance on personal contributions to the overall funding of the healthcare system have definitely occurred more frequently in research, media, general public conversations, particularly people who are paying directly for these. So what is financial toxicity? The Financial Toxicity Working Group of the Clinical Oncology Society of Australia a couple of years ago defined financial toxicity in the Australian context as the negative patient level impact of the financial costs of cancer, which are the combined impact of the direct out-of-pocket costs for medical treatment, indirect costs of care such as accommodation and travel costs, and the impact of changing financial circumstances on an individual and their household. And as a result of this loss of income due to cancer. These financial burdens can cause both physical and psychological harms, affecting decisions, which can lead to those suboptimal cancer outcomes. So those direct costs include things like private prescriptions for medicines that are not funded on the PBS, or co-pays or gap fees for medicines and services, for which we know a portion of those are covered publicly by Medicare, and then in some circumstances private health insurance. Those indirect costs are those other out-of-pocket costs such as getting to and from treatment, parking, over-the-counter medicines, and even things like extra daycare costs for people. So those really practical things that that people need to pay out of pocket so that they can actually get to treatment too. The changing financial circumstances recognises the impact of the changes to employment and income of people and their household following a diagnosis, which impacts their ability to continue to meet those everyday financial obligations and living expenses, on top of that additional pressure of medical costs. So the usual everyday expenses such as electricity, food, mortgages, things like that, they don't go away. They continue even if you've stopped work or are unable to work. So while there are some people more vulnerable to financial toxicity, it can happen to anyone at any time. And people living in the most socioeconomically disadvantaged areas are disproportionately affected. However, evidence is growing of the experiences of people who are financially stable prior to their diagnosis being unexpectedly impacted by the financial costs of cancer. Putting this in the context of Australia's universal healthcare system, no one should be financially disadvantaged by their cancer diagnosis and their treatment. However, it's currently not the case. So our dual public-private healthcare system means that cancer care services are frequently available in both the private and public sectors. So people can often choose which option is best for them. However, decisions can be influenced by the availability of local services, how fast someone wants to be seen, or what options are provided by their healthcare professional, or just even defaulting to using private health insurance because they've had it and they've paid for it their whole life. So these decisions can influence both the financial outcomes and health outcomes following cancer diagnosis. And for those who choose to access healthcare privately and use their private health insurance, they report higher out-of-pocket costs and unexpected bills. And here the experience is really around that perception that private health insurance will cover all expenses because I've paid for it, my entire life. So now I should really reap the benefits of that. However, there are many costs also in the public system. And not all healthcare that an individual needs is subsidised by the government. But Australia's healthcare system does produce amongst the best cancer outcomes internationally. So the graphs here just show you, they're from the International Cancer Benchmarking Partnership and compare 5-year survival across several countries in these 7 cancer types. So you'll see Australia's in purple in each of these graphs. And so we actually rank highest in 5-year survival in 5 out of those 7 cancer types. So we're doing pretty well. But when we look within our own population, not everyone experiences these exceptionally good outcomes. And the populations experiencing worse cancer outcomes are also those who report increased out-of-pocket costs, greater financial burden, and poorer access to health services. They generally live in the most socioeconomically disadvantaged areas, remote areas of Australia, and are Aboriginal and Torres Strait Islander peoples. So just looking at how this topic has evolved over time, although the definition of financial toxicity in the Australian cancer care context was defined by COSA more recently, the concept of financial toxicity has been talked about and has gained much interest over the past 10 years. Compelled by the rising healthcare costs, both to the individual and the health system, this editorial on the slide by David Currow and Professor Santiaranda in 2016 in the Medical Journal of Australia discussed the challenge of knowing your exact treatment pathway and how much it will cost you following a cancer diagnosis. So I think it was really quite an interesting spin, and they chose to liken cancer care and making decisions about your cancer care to a bit like looking at a menu without prices. So the costs are often not obvious or certain, and they vary depending on the type of treatment you have and where you choose to have treatment. The article speaks to structural and systemic issues and calls for medical practitioners to disclose costs affecting patient decisions and a standard for financial disclosure. So a standard that they define as that moves beyond the disclosure of costs for a single procedure to one that accounts for the costs across the full pathway of treatment and all the alternative or supportive elements that are available to a patient. So knowing that you could have treatment in the public system and what that might look like for you, also knowing that you have access to financial supports as well as part of your decision-making process. In this time too, several community organisations that represent different groups of people conducted surveys with their memberships or the people they represent and made some reviews of the impact of the out-of-pocket costs of cancer on their communities. While several peer-reviewed studies during this time aim to quantify the cost of cancer in real dollar terms, these reports really humanised the issue and kicked off the whole of cancer community conversation. And these really gave a voice to people and their experiences and how varied those experiences were and how actually quite challenging it is to put a dollar figure on what out-of-pocket costs are for cancer care, given all of the variables that can affect costs and people's decisions about their care. So just a few interesting experiences across these reports. So public versus private. Some people perceive that the public health system or their private health insurance will cover all costs necessary for their care. And people perceive that paying more for their care means they expect to receive a higher quality of care, but we haven't quite seen that play out in the literature, that relationship between cost and quality. Both high out-of-pocket costs and the accumulation of smaller costs over time affect people's psychological well-being and their decisions. And this experience is really diverse, from people making decisions about their treatment because of the hospital parking fee, to accessing superannuation to fund medicines that aren't subsidised by the government, and even where having treatment means they can't look after their granddaughter so that their daughter can go to work. So people are making decisions about their treatment that aren't necessarily only treatment focused. They're making decisions based on the financial implications. So if you usually look after your granddaughter on a Tuesday, but that could be one of your treatment days, then people are making decisions to modify their treatment because otherwise it means that their daughter or their son can't go to work and make an income for their household too. People are often unaware of the financial entitlements and supports available to them, and particularly how to access them, either through government programs such as Centrelink or their own financial assets such as insurances attached to things like superannuation, or the support from the non-government organisations, community programs, financial counsellors, and people who could self-advocate or had someone advocating for them, such as a social worker or a nurse, were able to more easily access these types of supports. So to some work that we conducted, we wanted to understand what policy and practice changes could be implemented to relieve this financial burden. So we undertook a systematic review to identify the experiences of cancer patients and the impact of out-of-pocket costs and financial burden on cancer care in Australia. I guess essentially trying to create our baseline, bringing together everything that had been published up to 2019, which is when we did this review. So 19 papers were included, However, I think if you did this again right now, you would find many more relevant papers to include. I think the literature in this space has really taken off in the past couple of years. So just a snapshot of what our systematic review showed. So relating to direct out-of-pocket costs, the average total out-of-pocket costs vary greatly across the studies where they tried to quantify cost, and across different cancer types as well. The indirect costs, the most commonly reported indirect costs were travel-related expenses, fuel, parking, even food for people who needed to travel to metro sites and I guess set up 2 kitchens, one back at home in their rural property where their family was staying, but also then where they needed to stay closer to treatment in their metro centre, and out-of-pocket, over-the-counter medicines to create some of this cost. And these costs also varied by region. So 30% in one study, there was 30% of rural patients reported travel and accommodation costs as their largest expense, compared to 13% for urban patients. And these indirect costs were also more prevalent in some situations, such as the ongoing management of lymphedema as a side effect of breast cancer, which showed that compression garments accounted for actually 40% of their out-of-pocket costs, and these were annual costs to them too. So for ongoing management, these were costs that they were incurring year on year. Relating to the financial burden and psychological distress, this in particular is associated with non-adherence to cancer-specific treatment, and some of the behaviours people, displayed were things such as delaying, modifying, foregoing, or not completing recommended treatment. And this impacted their health outcomes. People mentioned also modifying lifestyles or altering long-term financial plans to pay for cancer treatment, and they commonly drew on savings or sold assets, increased credit card limits just to pay for treatment. So a few risk factors relating to out-of-pocket costs or financial burden that were found in this systematic review. So being under 65 was associated with worse financial burden. Aboriginal and Torres Strait Islander peoples actually had significantly less out-of-pocket costs. And when we looked into this, they also spent less on Medicare-funded services. So actually, this was more of a signal about care variation than a bit of a win for paying less out-of-pocket costs. So we still want to be able to see people accessing the care they need, just without the influence of out-of-pocket costs. Not living locally to treatment resulted in greater financial difficulties. Lower household income also associated with increased odds of financial burden. Unemployment or job change because of their cancer diagnosis was an independent risk factor for worse financial burden. And private health insurance status resulted in higher out-of-pocket costs. Through doing this review and looking deeper into the topic of financial burden, we found that there were no obligations for healthcare providers to disclose costs or have discussions about costs with their patients, and there were limited guidances at the time to support someone to provide this type of information upfront to their patients. So it was really a bit of a hidden issue. No one really talked too much about it. So working with other organisations and advisors, Cancer Council Australia developed a standard for informed financial consent for cancer to recognise the complexity of a cancer diagnosis, the uncertain and changing treatment pathway, and the long-term impact on a person and their family, both of the cancer diagnosis and the financial decisions that come with having treatment and care. So this sets out 5 principles for discussing costs with patients and provides some key tasks as examples of how to achieve each of those sort of principles or elements at a health system, health service and health professional level. the aim of which is to improve transparency of out-of-pocket costs and support the patient decisions and discuss options so that cost alone is not influencing health decisions. So this concept also emerged a couple of years ago as a recommendation in the MBS Task Force Review Final Report, Recommendation 3, recommending that the government develop and mandate a consistent documented procedure with appropriate provision of information to assist providers in explaining costs to consumers prior to a course of treatment. So it's really around that course of treatment element. It's not a discrete episode of care. It's really who's involved in your care and what could the financial circumstances look like across the treatment pathway, knowing that some of these may change, but there are potential costs associated with your decisions. More recently, a few studies have aimed to understand healthcare professionals' experiences of having discussions about costs and financial burden with their patients. It's important to understand both the patient experiences and those of the healthcare professionals to start to identify and articulate where some of the opportunities are in policy and practice to support this conversation between the two people involved in making decisions about cancer care. So among oncology health professionals, just a bit of a snapshot of what was found, among oncology health professionals, most participants agreed it was appropriate in their clinical role to discuss financial concerns, and 88% believed discussing costs and financial concerns were an important part of providing high quality care. However, 28%, half of whom were oncologists, stated they did not have the appropriate information on support services or resources available to patients to facilitate these conversations, and that barriers to discussing financial concerns were things like insufficient resources or supports to refer people to, followed by a lack of time in a typical consultation. Another study of a survey of medical oncologists found that most oncologists felt it was part of their responsibility to discuss costs of care. However, a majority of those reported only discussing costs with less than half of their patients. So most oncologists were unfamiliar with cancer-related financial burden, and it was the oncologists that had greater clinical experience and those working in private practice who were more likely to discuss costs with a majority of their patients. So looking back to our own work, we wanted to understand what was happening in practice to support informed financial consent, where it was happening, and what strategies healthcare professionals working in oncology might be using at the moment. Our aim was to do this through implementation mapping, to understand existing pathways of establishing informed financial consent, to develop recommendations as to how informed financial consent can be implemented in various cancer clinical care settings. The research team and policy teams working on this project are named below. And I think that's an interesting collaboration between research and policy to ensure that we can really translate some of this into practice and provide some guidance that is evidence-informed around what might work in the system. Our publication for this work does remain under review though. However, if any part of this is particularly interesting to you, methodology or even some of our sort of, our combined research policy insights, I'm very happy to discuss and provide any of that further information to you. A couple of points on our methodology. So through our existing networks, we invited Australian health professionals providing cancer care who had self-identified as having informed financial consent processes in place to participate. We labelled them early adopters. We conducted semi-structured interviews using questions informed by the Consolidated Framework for Implementation Research, and these interviews were supported by a process map. The process map depicted the general process of how cancer patients progress from initial referral to the healthcare professional through to treatment and follow-up. It was used to highlight where informed financial consent strategies and practices were being used by health professionals that we interviewed. The interview transcripts were analysed using a deductive framework methodology that was guided by the constructs of the interview guide. A coding tree was developed that identified the common responses or themes from those interviews under those areas of interest. And barriers and facilitators for implementing strategies for informed financial consent in each setting were captured. So these barriers were coded to the cipher domains, and the strategies for obtaining informed financial consent were coded to strategies identified in the ERIC, or the expert recommendations for implementing change taxonomy. So our results, we conducted 10 interviews with healthcare professionals, and the informed financial consent processes and strategies did vary by professional specialty. We interviewed some GPs, medical oncologists, surgeons, and also by whether they worked in the public or private setting. Key components of informed financial consent were identified by combining those individual process maps and creating an aggregated process map. And themes from the interviews were grouped into barriers and enablers to the delivery of informed financial consent. And recommendations that we've made on the strategies to use to achieve informed financial consent, which we'll see on the following slides, were based on the key components of these process maps, as well as those barriers and enablers, so combining those two results. So the figure here presents the barriers or facilitators to influencing informed financial consent grouped by those cipher domains. So you have characteristics of individuals, outer context, inner context, and process. And the additional levels of this figure show where there are opportunities for strategies as identified by the participants to support informed financial consent, or where some of those barriers were that could be addressed to provide informed financial consent. So looking at a few of these, under characteristics of individuals at the top, people were concerned that they'd be misquoted about costs or get it incorrect, essentially. And also that patients may have informational burdens. So at the point of diagnosis, it's an emotional time and they're provided with a lot of information. And there were concerns that talking about costs might just add to that unnecessarily. In the outer context, people commonly spoke to formal guidelines or processes that either existed or didn't exist, such as having no method to screen for financial distress, like a formal training for themselves on providing financial disclosures to patients, and people were unaware of templates or resources to follow for providing informed financial consent. So these are some of the things that might help someone to have these conversations in the future. Across the inner setting, there was uncertainty about the flexibility of having care between public and private systems, and this notion of institutional memory. So healthcare professionals often said if they worked regularly with another healthcare professional, they knew their costs or the type of costs that might incur more frequently than if they were referring to a healthcare professional that they didn't know. So some people recalled the out-of-pocket costs or the total costs that someone might charge their patient if they referred to them, while others didn't really know where to look for this information. And around process, this was strategies to deliver informed financial consent. So, and we'll see this in the recommendations too, that people thought that having a dedicated financial officer, integrating informed financial consent as part of clinical discussions, and having software that streamlines informed financial consent processes embedded within their existing electronic healthcare software would really enable those conversations to happen more regularly. So this is the process map, or the aggregated process map from the experiences of all the people that we interviewed. So the process map shows the patient's usual referral pathway from diagnosis to treatment and their interactions with healthcare professionals and healthcare services. It does sit across four key phases, so referral and scheduling of the initial appointment, the appointment attendance itself, treatment and follow-up, and recurrence as relevant. The dark blue bubbles show the strategies that were identified by the participants that we interviewed, and also start to bring in some of those barriers and facilitators that they identified to inform financial consent, putting them into actions about and providing recommendations for how others could adopt similar practices in their work to support informed financial consent. So thinking about themes, there were a couple of key components that came out that would support informed financial consent. So the establishment of centralised points of contact to direct patients to discuss costs of care or to access information about costs of care. Similarly, having consolidated information delivery so that all relevant information was in one place, whether this was written or it was held with a dedicated person. Reiterating or having multiple touch points to reconfirm costs and people's options. And follow-up, so using follow-up appointments to check in about financial stress, particularly when there are changes to patients' treatment or financial circumstances. And you'll see some of these components are across the care pathway that's here. So out-of-pocket costs, so under referral and scheduling of appointment. So out-of-pocket costs for initial consult was discussed with the patient. So the administrative staff or the person who's booking it or the automated online booking system, there's an opportunity there to identify that there will be a cost with this appointment, maybe what the out-of-pocket cost might be, and any options under Medicare or private health insurance to reduce these costs. The second blue bubble there talks to out-of-pocket costs for the first consultation being reconfirmed prior to seeing the specialist. So another opportunity is that administration staff can reconfirm that cost so that people understand before they come to the appointment, again, what their costs might be. And then there's a larger component further down within the appointment attendance to the components within an appointment to discuss financial costs, so patient preferences for private or public options and what those implications are for finances, outlining any projected out-of-pocket costs, and details of additional specialists that may be required and where to find information about their costs. Similarly, when patients leave the consultation, administrative staff or others can talk to these financial costs, and patients can be given details of people who to follow up with to talk about any concerns about financial costs they have. The final bubble in the treatment and follow-up section is really around that key component of follow-up appointments being used as opportunities for clinician-led informed financial consent consultations. So checking back in with the patient to see whether their financial circumstances have changed, their preferences for care have changed, and to discuss any of these changes where other financial support resources might be required. So working in policy, we're always very interested in understanding what the government's doing to address a certain topic or issue. So in this case, influencing out-of-pocket costs and reducing that financial burden to Australians. And really that helps us to identify actually how some of these initiatives could be improved to meet the intention that they do have. So in Australia, there are safety nets attached to MBS and PBS funded services and medicines. So the out-of-pocket costs that you do pay or gap fees towards services or medicines, as they accumulate, once you reach a certain threshold, you then qualify to pay less for the remainder of that year. So these safety nets do reset at the start of each calendar year. So there has been some research recently by Kees van Gool around the amount of out-of-pocket costs paid depending on when people are diagnosed in the year, and whether there is actually an opportunity, instead of doing a calendar year safety net reset, should we be looking at something that is more rolling to better support and reduce out-of-pocket costs for people. The Medicare Cost Finder website was introduced to improve transparency of out-of-pocket costs charged for some privately provided services. However, more recently in Parliament, a question was asked of the Department of Health about the utilisation rate. So how many doctors were voluntarily putting their costs on this website for people to find. And their response was that only 20 doctors have voluntarily contributed to providing their practice information and costs since the website was launched. And this was launched a couple of years ago now. So it obviously hasn't hit its mark, but the intention is that it is there to provide people with choice and options, but needs to be widely used. I touched on before, there was an MBS task force review conducted a couple of years ago, and within their final report, they do have a recommendation around developing and mandating a consistent documented procedure, essentially informed financial consent for people prior to undergoing healthcare. There's a strengthening Medicare initiative. So this is around primary care workforce and working to scope of practice and where the opportunities are to create those efficiencies and supporting the primary care workforce. And there is a current review at the moment of National Medicines Policy and Health Technology Assessment Policy and methods. So really looking at how the regulatory system assesses and approves medicines and funded services to identify what should be funded publicly in the health system. So that's kind of ongoing at the moment, and we're waiting for the final report and then the government's response and commitment to meeting those recommendations. So just in closing, I thought I'd just touch on a couple of initiatives about, I guess, where we're going next or what's happening in the financial toxicity and cancer care space. So COSA released its financial toxicity roadmap, and this roadmap sets out 5 priority areas, each with further actions within them, to really bring together the community that's committed to reducing financial toxicity to work collectively and collaboratively on solutions for this. So those 5 areas are collective advocacy for financial support for all people affected by cancer, a shared role for cancer care services in reducing financial toxicity, ensuring access to information and support that enables informed decision-making, creating supportive work environments and financial protections through reform, and fostering a collaborative research community translation into practice. So really finding solutions that are going to work for Australians and being more collaborative and planned in our research together to finding these solutions. And just on the right there, Cancer Council Australia last year released its financial cost of cancer policy. It sets out 4 areas which are listed there, each with multiple policy recommendations underneath them, aimed to address the financial cost of cancer at a national policy level. And I guess similarly to some of the topics we've talked about today, the first one is around implementing a standard for informed financial consent. Second, around improving experiences of people with cancer who require income support payments, so addressing that burden around loss of income or ability to work following a cancer diagnosis. Improving financial support for people living in regional and remote areas to access cancer treatment and care, as we know that they have greater financial burden and experience those more indirect out-of-pocket costs associated with travel and accommodation. And that fourth one around increasing access to financial counsellors for Australians. So providing greater access for people to talk to someone about what their options may be at a time that could be financially stressing for them, and what they may have access to support themselves financially, or access to putting things on hold, such as mortgage repayments. So thank you for the opportunity to present, I guess, on financial toxicity, financial burden, out-of-pocket costs, where the conversation started, where we're going, and some of those initiatives in between, drawing on implementation research, methodology and thinking, and hopefully the opportunities to do more of that in the future, to find those solutions-focused research projects and options for us to translate into policy and practice. So that's really where I'm interested in. How can we learn from your skills and your methods to create the evidence that will have a real impact on people affected by cancer? So if you want to have a conversation about any of this, or need some clarity about what I've said, please feel free to email me there, or to connect on LinkedIn as well. I will be going on some leave from mid-July. So yes, please feel free to also connect on LinkedIn to continue the conversation. Thank you.